Thank you for joining us this evening. I'd like to welcome you to the IU South Bend Civil Rights Heritage Center and the program and event we have tonight co-sponsored with the Dwyer School of Health Sciences at IUSB. I am the director of the IU South Bend Civil Rights Heritage Center and an assistant professor in the Women and Gender Studies Department. I will turn it over for a welcome also from the Dean of our School of Health Sciences, Dr. Thom Fisher.
Thank you, Dr. Heller. Good evening, everyone. As Daryl shared, I am Thom Fisher, and it is my privilege and honor to serve as the Dean of the Vera Z. Dwyer College of Health Sciences at Indiana University, South Bend. Welcome, everyone, for your presence here for this evening's important conversation. This is a conversation that was conceptualized and developed by our College Inclusive Action Advisory Council. And this council actually is an outcome of our 2018-2023 strategic plan in the college to reach diversity with our students, faculty, and staff. Our college graduates approximately 220 students each year who will contribute to the health and human service industry to full-time vocational calling in our local community and region. When the Board of Health passed a resolution and unanimously declared racism is a public health crisis in St. Joseph County on July 15, 2020, we as educators, health professional, and student services personnel and others were drawn to more deeply commit ourselves to addressing the healthcare disparities in our community. One way we practice this commitment is to anti-racism is by creating spaces for dialogue. What is the story of this resolution and what does it mean for St. Joseph County? Tonight, we will hear from experiences of health practitioners, educators, and administrators about racism in our community. This will feel uncomfortable and challenging, as it should be, but we have the invitation and the opportunity to remain open-minded and lead with curiosity and a fierce belief in dignity of everyone. On behalf of the Vera Z. Dwyer College of Health Sciences at IU South Bend, I sincerely thank the Civil Rights Heritage Center for your participation in bringing tonight's event together. To our panelists and the healthcare administrators who will offer their responses, thank you for your service, your candor, and your desire to address the health crisis of racism in our community. We are committed to doing this with you. I will turn this back to Dr. Heller and mute my video and mic to help with bandwidth. Thank you.
Great, thank you, Dr. Fisher. Before we begin tonight, I would like to take a moment to acknowledge that the land on which we stand is stolen land. It is the traditional homeland of the Potawatomi, the Miami, and the Delaware. We acknowledge that many deaths that have resulted from their forced removal, as well as honor their spirits that remain. I think it's important to make that acknowledgement, particularly in light of the topic that we're discussing tonight. People of color have suffered disproportionately negative effects of the healthcare system that has created structural barriers to access and has led to outcomes that are too often inadequate and harmful. None have paid a higher price for this than Indigenous people and people of African descent. In July 2020, the 7 members of the St. Joseph County Board of Health voted unanimously to declare racism as a public health crisis that affects all members of our community and deserves action from all levels of government and civil society. As I go on, so that is the framing of our conversation this evening. I would like to take this moment for our panelists to introduce themselves and just say a word about who you are and what you do. And I'll start to my right with Yolanda.
Greetings, everyone. Again, thank you for having me. My name is Yolanda Washington. I currently serve as one of the nurse consultants for Beacon Health System, dealing with the pregnant moms and the parenting moms, young teenagers. I'm also serve as the health manager for the for the St. Joseph County, as well as the Elkhart County Head Start Consortium, where I deal with the infants, toddlers, and the school-age mothers program. Again, thank you for having me.
Great, thank you.
Good afternoon, everyone. I am Leanne Young. I am the Trauma Program Director for Beacon Health, and I oversee the trauma programs at Memorial Hospital and Elkhart General Hospital.
Good evening, I'm Heidi Beidinger, and I'm the president of the Board of Health for the St. Joseph County Health Department. I am also a faculty member at the University of Notre Dame, where I am the director of the Master of Science in Global Health program.
Wonderful.
My name is Jayandra Tisdale. I teach psychiatric mental health nursing for a local college here in South Bend, well, Notre Dame, Indiana. And I have been a psychiatric mental health nurse for 13 years, and it is my passion. Thank you for having me.
And I'm Barb White, and I am the interim assistant dean of nursing at IU South Bend. And we know that educating new nurses about racism and its impact on health and bringing up and raising more nurses of color is really important for this problem. And so that's what I bring to the table this evening. Thank you for having me.
Great. And we're extremely proud to have this esteemed panel for this discussion tonight on racism as a public health crisis. The resolution that was passed by the St. Joseph Board of Health is pretty comprehensive, and we're extremely proud of that as well, and thank those who participated in making it. We'll go into some of that. For your benefit, and those of you who haven't read it, I just want to give you a short summary of the resolution itself. If it declares racism as a public health crisis, and it defines racism in part as a system of structuring opportunity and assigning values based on the social interpretation of how one looks, that unfairly disadvantages some individuals and communities and unfairly advantages other individuals and communities, and saps the strength of the whole society through the waste of human resources. The resolution itself is clear in that it acknowledges that racism has lifelong health effects that begin even before birth. Racism increases the risk of emotional and physical health problems, has historic and contemporary roots, and has concrete repercussions locally that can be seen in the fact that infant mortality in St. Joseph County is 3 times higher than that of white infants. And Black life expectancy in our county is 5 years shorter than white life expectancy. The economic implications are such that 43% of Black children in St. Joseph County live in poverty, as compared to 14% of white children, and Black median income is half of that of white households. In light of these facts, the St. Joseph Board of Health committed itself to engage in frank and open discussions on race and the impact of the decisions we make upon racial inequities in our community. They've also committed to provide educational opportunities for the Board of St. Joseph County Department of Health on matters of racism and implicit bias, and to promote greater diversity on the Board of Health. And additionally, provide a health equity epidemiological and data unit within the St. Joseph County Department of Health that will conduct equity-focused health impact assessments, define baseline data regarding health disparities and equity in St. Joseph County, and identify factors contributing to health disparities. Additionally, and I think equally important, it's committing itself to explore with law enforcement, emergency response units, hospital systems, behavioral health systems, and other local and state partners, the feasibility of creating, funding, implementing, monitoring, and evaluating a pilot program of crisis intervention consisting of interventionists employed by the Department of Health to provide mobile crisis intervention and response to non-criminal situations such as substance abuse, mental emotional crises, and dispute facilitation, as well as providing assessment, intervention, and transport to services as needed. These are just some of the acknowledgements and recognitions that the County Board of Health has made that shows South Bend is just another microcosm of a larger national health crisis, but we're dealing with our little part of the world here. And I actually want to turn to Heidi and just ask you a couple of questions, because I think one of the things we're really curious about and interested in knowing more is how this resolution itself came into being. Like, what was the process and what was the thinking?
Right. So again, thanks for having me, and thanks for taking us through a summary of what the resolution is and bringing that focus and attention to it. So, like many of all of us, we were experiencing COVID, but we were also experiencing the tragedies of George Floyd and the many other people, Black people, people of color, who have been murdered by police officers and law enforcement in our country. And it really was that confluence of what was going on in our country that suddenly pulled back the curtain to say, something is wrong, and it is really wrong. And I know that it was wrong before, but suddenly somehow now this was the catalyst and this was the moment. And frankly, we heard other cities now were starting to do this, and we were like, this was our mindset, and we're like, we're ready to go. Let's go ahead, let's do this.
So was it Milwaukee that was that initiated?
That's right. I think Milwaukee, Madison, and Pittsburgh had already done it, I think actually like last November or December. And so then I think there's over 50 cities or jurisdictions now who have done something similar.
And for our Board of Health, what was the process? Like, once you recognized that we needed this kind of statement here and the actions that it calls for, what was the process of actually putting it together?
Yeah, so I took the lead from the Board of Health side, and our health officer, Bob Einters, who is new to our committee. We recruited and hired Bob Einters from IU, and he started here in February. And then, of course, was hit with COVID, just like all the rest of us. So he took the lead from the department side. And so between the two of us and others from the department played a role in putting this document together. And so we used our own local data to go into this. We researched the different definitions of racism and so forth, and documented that here. And then the things that we would hold ourselves accountable, we had conversations among ourselves to say, what are we willing to do? What are we willing to hold ourselves accountable to? So we got the document drafted, circulated among the board, just like you would do in a rather democratic process, circulated among the board and the entire Department of Health staff. That whole group saw it before it ever became public, and everybody had an opportunity to give feedback and input into the process.
Great. And that's wonderful. So, and what is the outcomes you hope for? What are the goals? Like, in putting it out, what do you want to come out of it?
Yeah, so I made a little list because I gave this a lot of thought, because in the beginning, there's so much work and energy that goes into creating such a document, right? And then you've got these words on the paper, and it's like, what are the next steps? Like, is this going to end up just being this meaningless little document that gets stuck, somewhere, and we'll pull it out once in a while? But no, that is not our intention. We wanted this resolution because we want to bring attention to this crisis. It gives people a reason for changing their behavior and their thoughts. I compare this to the time when smoking was popular, and remember, it was C. Everett Koop, our Surgeon General, who was the one who declared that was a public health issue in crisis. And so we have to attach that language to it to give it that severity and that attention. And I believe that this is the first step for us to dismantle racism in our community.
Great. And finally, I want to ask you, I'm going to bring other folks into this, but I want to just, as you were kind of going through this entire process, did you think about, or do you have a sense now that it's out in public, what the community's response is, and kind of how has folks come back to you?
Right. So the reaction actually was rather anticlimactic. So that was, that was a bit devastating actually, because you put so much time and energy into it and you want to do a good job and represent the Department of Health and the Board of Health well, right? So a lot of effort went into it and no one asked us about it. It was all COVID all day, right? But at the same time, I think it's actually okay that it happened that way. Our health officer likes to say something along the lines of, let's celebrate when we get things done rather than talk about the things that we're going to do, right? So he reminds me of that often. And so that's exactly what we did. So we just laid low and we started implementing what we said we were going to do. And I brought along a list of some of the things that we have already done. And that is, when did this get signed? I think it was in July.
In July.
In July, and here we are at the end of October. We've created the new unit called the Health Equity, Epidemiology, and Data Unit. They are enabled to be data-driven, respond to disparities, and they will empower us with the data about racial disparities and so forth. We have already recruited and hired 2 community health workers. One is Black and one is Latinx. We've recruited a new food safety employee of color. We've implemented 2 COVID testing sites in a Latino community and the other one in a Black community. We're following up on folks who've attended those 2 sites but did not have insurance in an effort to connect them with third-party payer sources. We have also held our first implicit bias training this past Friday. Awesome. And oh, by the way, we contracted with a local trainer, so that's awesome too. The Department of Health is now at the table with persons responsible for responding to homelessness, including participating in Mayor Mueller's task force. The department played a major role in administering and providing the services for isolation and quarantine at Motel 6. We promoted participation in the rallies and prayer rallies that happened around the time of George Floyd's death. We have met with Black Lives Matter leadership. We've hired the first ever social worker within the Department of Health, and she is a Black female. And we've given public presentations around this topic and about health disparities. For the Board of Health, of course, we've declared this resolution. We currently have an open seat on our board, and we are recruiting specifically a nurse and a nurse of color. And we are engaging in our own implicit bias reflection. I'm not calling it training yet because I don't have funding to do that. So we're doing it on our own. And then part of our strategic plan is to actually hold our department accountable for the things that we said we were going to do. And then, of course, participating in this panel.
Great.
This is another way for us to share the message. And I'm so happy to be here to be having this conversation.
That's great. No, thank you. It sounds like you've kind of hit the ground running with it.
Yes, yes.
And I particularly want to bring in the rest of the panel. I mean, so what? And you can go in any particular order. What has been your sense of the response in the community? Have you heard people talk about it? Has it been part of your own conversations in your fields and in your work? Just what's the response?
I'll go ahead and start. There has been no reaction in any person, group, or anything that I have been in contact with, which is why I think the committee, the inclusivity committee from the Dwyer College of Health Science, wanted to sponsor this event, because we felt that the response from the community, even the media response, was inadequate for the proclamation. I mean, it's a pretty bold declaration, and we thought that it deserved more attention than what it received. And so I don't hear any scuttlebutt on the street, talking really about it, and that's a disappointment to me.
Yeah.
And I have to agree with Barb. I really have not heard anyone talking about it out in the streets. And like I said, I pretty much live in the community with dealing with the population that I serve, and it has not been an issue. It has not been brought up in any of the conversations that I've had with anyone.
So I heard about it when I was invited to participate in the panel. And when I read it, my first reaction was, finally, welcome to the conversation, Board of Health. Thank you for coming. This has been an issue, not just in this community, but in communities across the country. And yes, the recent events in our nation have pulled back the curtain, you're right, but it's about time that we have frank, open, honest conversations about the fact that racism is an issue and it's going to affect people in our community until we start doing something about it. So it wasn't until I read that it was signed in July that I realized it had been out for so many months. But it's a valuable document. I think you're right that we should celebrate once we have something to celebrate, but I think you guys need to be applauded for taking a stance. And it's significant, especially for an individual of color in this community.
And again, just to build on Leanne's thing, and again, just kind of open, how have you experienced racism in the healthcare system, in the ways that you engage healthcare here in this community? What does that look like, or what has it looked like from your experience?
Well, especially in mental health, what I've seen as far as mental health is that certain expressions, certain ways that the different ways that people interact and communicate can sometimes be misinterpreted. And especially in African Americans are more likely to be diagnosed with schizophrenia than their white counterparts, who are most likely diagnosed with the mood disorder. And that comes into play when clinicians interpret their behaviors or interpret the way they communicate. For example, with paranoid thoughts, in the Black community, suspicion and mistrust can often be miscommunicated. Like, for example, if a clinician were to ask me, do I think that people are following me or watching me? And if I were to say yes, because I recall the situation that happened to me at a store, that someone was following me, I might be misdiagnosed as having paranoid thoughts. So those are certain issues that I have seen in the communities as far as when clinicians may not be culturally sensitive to what's going on.
Daryl, can I back up just a little bit to the previous conversation? And this is just a personal from my perspective. You know, I am personally appalled and saddened yet by the injustice that we still continue to see this day. I'm also shaken by the reality that we're still yet dealing with the disparities and the lack of respect for the Black and brown community. Racism didn't just start. Racism has always been here. And it hasn't gotten worse, but technology has caught up with it. So now it's being exposed. George Floyd, he wasn't the first Black man to die in the hands of white police officers, but we were not able to prove it because we did not have cell phones. We did not have people witnessing, watching it, and taping it at the same time. So it's not new. But the fact remains, the health disparities, as well as the racism and discrimination, has been brought to our attention way back in the 1980s. Here it is 40 years later, and we still have not made any progress to it. The resolution, it's wonderful. I mean, I applaud you. I'm glad the health department has stepped in, but we have to take it further. The steps that you guys have taken, it's a start, but it's not a finish. Oftentimes, we sit around at these little tables, or square tables or round tables, and we come up with all these wonderful plans, and then when we leave, the plans stay there. So I think we have to continue to move forward, and we have to push it, and we have to make everybody aware of it. We also have to do a self-check to see where we're at on the spectrum and correct our indifferences as well, and to teach everyone and deal with the problems, accept that it is a problem, and then yet have training on how to deal with the problem.
Yeah, did you want to?
Yes, so I'm processing. So you are exactly right. This is the first step, right? And by no means do any of us at the department or Board of Health have any corner on understanding all the complexities, right? So it's the first step. What I would encourage all of us here and our listeners and so forth to reach out to us to say, here's what more could happen. Here's another thing to think about. And if we're falling short, to push back on that as well. I mean, this is the time. This is it. For me, I feel like in my lifetime, that this is the time for us to be engaging in these really tough conversations and making that move now. But I encourage the listeners and anybody around this table to be reaching out to us on the Board of Health and the department. I know that my health officer is equally eager to have these conversations. I mean, even before he was installed as the health officer, he was already doing a listening tour. He was meeting with folks in the community, he was meeting with leaders and so forth. He is very open to talking about this, having a conversation, making changes, learning as we go, et cetera, et cetera. So I so appreciate your comments.
You know, and I think that one of the critical pieces of any kind of solution is identifying what the problem is, really identifying. So what does the problem look like? Like, again, in terms of your practices, what does racism in healthcare look like? Who's affected? What are the issues? What's the service given or not given, like from your perspective?
So one of the things that I loved about the resolution that you wrote was that it moved blame from individuals to blame on racism that has been in our country for 400 years. So taking that step of moving the blame from individuals to the system means that now as healthcare practitioners in our community, we can start talking about racism at the bedside. We can start talking about racism in patient interactions, in client interactions, in public forums where we're talking about health, because I have not witnessed that. I have been a clinical nurse in this community for over 35 years, and I have never heard a practitioner acknowledge to a patient that maybe their blood sugars might be out of control because of racism, that maybe their hypertension might be difficult to control or might even be caused by racism. I haven't heard those conversations going on. And so what we end up doing is telling individuals that they're eating too many tortillas or, you know, too much of this or whatever. And they're, you know, and blaming the individual instead of blaming the system, which is a predominant cause of their health problems. And so I'd like to see us have many more conversations at the nurses station and with our, you know, in our rounds, in our care conferences, and talk about the impact of racism to take some of that relief, that stress off of our clients who are just so burdened, and it shows in their health, so burdened by the impact of racism.
Mm-hmm.
I think how it manifests really depends on the healthcare setting, right? So there are a lot of subtleties associated with racism in the healthcare spectrum. So we have patients who don't get appropriate pain medication because they're Black, or we have patients whose pain level just isn't believed, right? So Black patients tend to exaggerate, is a common misconception. Or we have healthcare providers who will present patients on rounds, and it's only when the mechanism is attributed to violence that the patient's race is brought up. So you'll have 52-year-old male MVC, motor vehicle crash, and then you have a 27-year-old African-American male gunshot wound victim. So if the race isn't relevant with a car crash victim, why is it relevant with a gunshot wound victim? So it's some of those subtleties that permeate and create the system of institutional racism that cause the poor outcomes for patients. Just from a trauma perspective, because that's my passion and that's my umbrella, our trauma population, we have 10% African Americans, but of our mortalities, 22% are African Americans. That's a problem. You see it in COVID as well too. The mortality rate for Black people who from COVID is significantly higher than any other racial group. And so we have, by not addressing it intentionally every single day with every single provider, we are allowing this system to continue. And it's not until we have these very difficult, uncomfortable conversations and get rid of those people who can't get on board with the fact that it's time for a change, we're just going to continue to see the problem.
And I have to agree with what Leanne just said. There is unequal treatment, and it's definitely noted in the medical aspect of it, especially with the pain medication. I've had even people who tell me they've been in pain, Black people tell me that they've been in pain, but because they have been mistreated, from going to the doctor's offices or to the emergency room and not getting anything for the pain, they decide they don't even want to go. And so those individuals, what they do is they turn to the streets, or they turn to any way that they can to get relief of the pain that they're experiencing, not realizing that part of your pain is because you've been treated unfairly for so long that has taken a mental toll on them.
Yeah, and I was really happy to see that there was that they adjusted the whole mental health issue, particularly the way that unfolded in communities of color, and the way I think that you were describing. How have you seen that, both in terms of the response to racism and how that affects people's mental health in communities of color?
Well, sometimes I feel like there is often a fear, and this is just my own personal experience, but I have a true fear of seeking medical care. I have a fear that I won't be believed. I have a fear that I have to plead my case, that initially, that no matter what I say, it's going to be discounted. And I had an experience where when I sought medical care for some back pain that I'd never had. You know, I'd actually fallen because the pain was so unbearable, and I'd never, I thought I was having a stroke. I didn't know what was happening, and I went to an emergency room, and I hadn't been seen, and all of a sudden this doctor came in and said, well, we think it's arthritis. And he was about to discharge me. And I said, well, I'm concerned, I don't know what happened, what happened to me, I don't know if I had a stroke. And he's like, well, what were you doing when you had this pain? And I said, I was getting ready for work. He said, work? Where do you work? And I said, well, I'm a nurse at such and such hospital. He's like, oh, okay. Well, let's order you a CT. Let's order you an MRI, and we'll see what's going on. Like, I had to I felt like in that moment, I had to prove that I deserved care before I would even get seen. And I know that was my own personal experience, but I'm a nurse, and I have a distrust myself when I go. So I can't imagine the distrust that other people have in the community.
That's a great point that you brought up, Deandra, because you reminded me of a time when my father was experiencing some pain himself. He had slipped and fallen and actually ended up hemorrhaging on the brain, as a result. But gratefully, all things worked out well, and he's still doing fine to this day. But even in the midst of going to the emergency room, one thing, I just don't go into the emergency rooms or in any medical facility and just say, oh, I'm a nurse. I never do that, because one, I want the same treatment that you would treat your family member if they came into the emergency room. So I never say that. And that same instance, again, they didn't want to do a whole bunch of things that I knew that should have been done in that particular case. And then the doctor or the nurse happened to be looking through my father's files and noticed that that my name was Yolanda, and I was a nurse that worked there at that particular hospital. And so things changed. Oh, we need to get this, this, and this, and this, so, but had they not known that I was a nurse, then he probably wouldn't have gotten that treatment at that particular time.
And the studies over the years that have been done for the last 20 or 30 years, I mean, this is not new information. The studies have been very clear. The time to pain medication is longer for Black people than it is for white people. The amount of pain medication is lower for Black people for the same fractures or sources of pain than it is for white people. We know that for Black people, the time to cath lab when they come in with chest pain is longer than it is for white people. We know that nurses at the bedside of neonatal intensive care units, that the nurses attend to white babies more than they attend to Black babies. No NICU nurse in the world wakes up in the morning and says, I'm going to pay more attention to my white babies than I am to my Black babies. So this, this brings out, and of course it's brought out in the resolution, but it brings out the importance of how embedded this systemic racism is and how intentional we are going to have to be to fight against it, which is why it's not sufficient to not be racist. What this demands is anti-racism. So what we need in our healthcare communities, in our agencies, in our conversations, in our nursing units, in the community, in our forums, what we need is anti-racist talk. And that's not happening in our community.
You know, I would add to what everybody here is talking about. So one of the areas that I do some research in is infant mortality. And so I was working with our local Department of Health on interviewing moms who had lost a fetus or an infant. And this is in our local community. I read the studies, you know, that say that women of color are not being listened to, right? They can call in, I'm having pain, the kicks have decreased, and somebody on the other side will say, don't worry, this is normal, call us later, you're only at 7 months, don't worry about it, right? So we did these interviews for moms who had lost their fetus or an infant, and the same exact stories. You guys, it was eerie. It was almost if they had read the study and were replaying it right there for us. And the other thing that probably saddened me even more so is that it's happening here. I think we want to usually believe that it doesn't happen here. That's someplace else, a big city that's, you know, impersonal and everything. But you guys, it's happening right here. Women have lost a fetus or an infant, and they have called in to say, now that doesn't mean that it may have changed the outcome. But the point is to preserve the dignity
service
and the quality of the care for the mom.
Right.
And that was not honored. That was not honored.
I just have to say something again, Heidi, and because I'm out here in the community, I see this stuff, I deal with this stuff. And part of one of my responsibilities with Beacon Health System was prenatal care coordinator. And so I followed women during their pregnancy, one, to help them get access to care early and get into prenatal care with the physician early in their pregnancy. And so some of my clients who would experience, you know, the low kick from their babies would call and say, hey, this is what's going on. The first thing I say, okay, call your physician, let them know what's going on. And of course, they talk to someone on the other end. It's okay, it's gonna be fine, you know, stay home, do this, do that. Whereas a woman of white color, if she has the same problems, baby's not kicking as well, she gets an immediate appointment with the physician. They're gonna do an ultrasound and check that umbilical cord to make sure that umbilical cord is not wrapped around that baby's neck. So I've dealt with that, I've seen it personally, so.
Yeah.
Is there anything, again, any of you and all of you think that what role does the community have in making and putting flesh on the bones of this resolution, in making this resolution not only a feel-good document but a real living document that actually is addressing real issues in the community? Can the community play a role in that?
I think the community needs to hold the healthcare institutions accountable. It's not just for the Department of Health to say, this is what we're going to do from a leadership perspective, and these are the things that we need to roll out. But as members of the community, when we're engaging with healthcare providers, we need to call out the injustice and call out the implicit bias and the racist comments and the disregard for pain or disregard for concerns from the patient perspective, and never tire of doing that. And that's the challenging part, because when you're constantly having to bring to the attention of individuals that that's not okay, and it doesn't seem like anyone is listening, you get exhausted. It's very exhausting. But I think we have a responsibility to not falter from that mission, keep having those uncomfortable conversations until we no longer need to have these conversations.
If you don't mind, I also have something to say about that too.
This is why you're here.
So, in order to control and fight racism, we need to recognize first that there is a problem. That's step number one. Then we need to start with a self-evaluation, and we need to identify and to control our own biases, our own insecurities, and our own prejudices. We need to get rid of negative stereotyping. We have to get rid of that. We need to figure out what happened to that individual to make that individual prejudiced or racism, because something has happened in their life to make them treat others the way they do, whether it was the way they brought up, whether it was something that maybe a Black person did to them, whatever the situation is, we need to figure it out. Then we need to manage it. We need to learn from it. We need to educate others. We need to make a commitment to treat everyone with dignity and respect. We need to have the appropriate classes and training incorporated in the medical trainings and professions and in all institutions and organizations and included in orientation. You're going to work from the bottom up and the top down. So you're going to include everyone. No one will be left out. Racism and discrimination has often been tolerated in institutions and organizations. In other words, other individuals cover it up. We need to expose them all. That's how we're going to deal with that problem. And then you're going to need to recruit more providers from the disadvantaged minority Black background, from the Black and the brown skin. And then we need to identify, implement, evaluate our strategies to eliminate racism and discrimination. And we need to keep doing it until we get it right.
And Yolanda covered a whole lot of ground there. But yet I have something to add. I think we need to have racism, racial equity at the center of every conversation, every decision made in healthcare agencies. So instead of saying, what can the community do? I'd say that the community needs to hold us accountable. But first, I think our healthcare agencies need to invite the community to the conversation. And then I think that they need to listen, and they need to listen again and again and again and again. And whatever they hear from the community needs to be spoken at staff meetings, at all kinds of forums. They need to be sponsoring these forums. Race needs to be the center of every care conference, every home care visit, every hospitalization, every report off from shift to shift, inpatient. Race needs to be the center of the conversation. I know that St. Joe Med Center embeds their spirituality into every meeting that they have in the institution. Racism, anti-racism needs to be embedded into every healthcare agency meeting and gathering that happens in this community, and that's going to fight this.
So what I would add to that is that begins with leadership.
It does.
Right? So it has to start from the very top. So our CEOs of our hospitals, South Bend Clinic and so forth, have to be willing to engage. So I'm kind of curious as to, I wonder how palatable that is. Are we ready to go there? Right? So do you think that the healthcare institutions around here are ready to have these kinds of conversations?
Heidi, what a perfect segue.
I know.
Let's find out if they are.
This is a great time because we have some health administrators to participate in this conversation with us. So I would like to bring Carl Buchanan, the South Bend Police Chief, Craig Gruber from the Beacon CEO, and LaToya Green and Christin Zollicoffer from St. Joseph Health Systems into the conversations.
So Daryl, if you read that note I just passed you, Craig is not able to make it.
Oh, Craig is not here. So Craig is not joining us tonight. Though he says, no, his Zoom, just to give full explanation, his Zoom isn't working for some reason, but he was looking forward to joining this conversation and sends his apologies.
We need to start correcting it right there. We need to make each other available.
Right.
To make it happen. We can do everything else when we want to do it. We need to make it happen. No excuses.
So I'd like to ask our administrators, those who are out in the community, face to face on a daily basis. After listening to this conversation, what are your thoughts both about the resolutions and about what's been said? I'll start with you, Chief. Do you have any thoughts about the conversation, about the resolution that you could share with us? Because the fire department plays such an important role as first responders in all of our communities. And so, yeah.
Thank you, Daryl. I appreciate it. And yes, I do have a few things to add. I'm honored to be here to engage in this conversation with everyone. I'm glad we're having this conversation. Lots of times, as we all know, and what has been said and spoken is that we don't get involved in these conversations until after the fact of something negative happening in the community, and then the conversation is being had. Well, the conversation was already prevalent before the act even happened. It just wasn't being spoken. And so I applaud everyone here for just being here and being a part of this conversation. And thank you to the panelists as well. So let me just say the resolution is an awesome It's awesome to see and to view. But again, what has already been spoken is that we need to actually view it being seen as a resolution or a resolve to the issue of racism, where racism is indeed everywhere. And being on the fire department, I can tell you in all of my 34 years, I have seen lots of racism, and it doesn't always come from people of color. It's just people in general out there and their perception of people of color, regardless whether they wear a badge or not. I've been in people's homes where people may not want me to provide medical attention to them because of my color, the skin color, but yet they will allow my counterparts to serve them. And I've seen also the opposite. I've been in some of the Black and brown communities where I'm more accepted and some of my counterparts are not. So let's make sure we're clear, define that racism is not just racism towards the African American or the Black or brown community. Racism is an act of racism against everyone, no matter what their color is. So the fire department, what I've taken since I've gotten up here at the helm, is I've always made sure that I project what my standards are to my rank and file that follow me. So I believe that as long as if I was one that was stating to them that racism was not going to be a part of this department, then I need to make sure that I project that same sentiment. And I expect everyone from the top down and the bottom up to say this, to think the same way. But racism has always been out there, and the only way we're going to eliminate it is not just by just having these discussions, but getting more people on the platform, more media attention. As we all have seen with the upcoming presidential election, they can buy ads and put all of this propaganda on TV for God knows how much money it's costing them. But you know what? How much are we willing to spend or engage on to eliminate this racism in our community and disseminate racism to not be a public health crisis in our community? How much are we willing to pay for that? Are we really willing to go all in, or are we just wanting to engage in conversations? I'm just asking that question.
No, thank you. And I want to ask both to you, Chief, but also to the panelists. Like one of the things I know in the fire department, as well as many of our other civil service positions, is kind of finding people of color. Do you think that having more nurses of color, doctors of color, firefighters of color, paramedics is an important, is that a significant part of resolving this issue?
Yes, I can answer.
Say more. Say how and why.
I do. Honestly, I do think it does make a difference because, again, let me go back to prenatal care coordination. When we do have, and I've sat on the board, not the board, I'm sorry, the coalition meetings that they have for infant mortality. And I've also dealt with a parent who lost a child, okay? Because being a prenatal care coordinator, that is what I do. Follow them throughout their entire pregnancy and 1 year after. But when an individual lost their baby, they would reach out to me, they would communicate with me, they would talk with me because I am of color and I can relate to them. That's what they see in their eyes. Whereas opposed, one of the other prenatal coordinators tried to reach out to the individual who lost the baby who was not Black. She wouldn't have anything to do with her. Mm-hmm. But because I was of color, she felt that we could relate, and they see women of color, I can relate to her, I'll talk to her. So I was able to reach the young lady versus the other one.
Mm-hmm. I think so often there's an inherent lack of trust for leadership. So whether that's in the fire department or the police department or in the healthcare industry, as a result of historical experiences. Mm-hmm. And the more we have a healthcare system that looks like the community we serve, the more we'll be able to break down those walls of mistrust. Mm-hmm. And I think we need, as members of these healthcare organizations, we need to be intentional about promoting a diverse workforce. And there has to be intentionality in hiring practices, in how we promote individuals, or how we create opportunities, reaching out to nursing students who are from disadvantaged areas to say, you know, think about nursing and advanced practice, think about nursing in a leadership position, reaching out to our medical schools to say, you know, going to community health so that you can not just be a physician or a practitioner, but be one that's going to be able to reach out and meet people where they are. Because we know that sometimes they won't come to the hospital because of fear, but we need to go and meet them where they are so that they can get the health care that they need.
And I think one of the points I would underline that question, you hit it on the head, is this issue of trust. And I think this is what you were pointing to as well, Chief, you know, that who do you trust? And so I know for myself, I'm like one of these old Black guys who don't go to the doctor, you know, until you absolutely have to go. And it's kind of both historic in the sense that my dad didn't go to the doctor either. But as I've learned more, it's because of this historic mistrust of doctors, of hospitals, of not feeling comfortable, you know, having, back in the day, certainly for my dad, but by and large for me, if I go into a hospital or a doctor, it's going to be somebody white. They're not going to really understand me. They're really going to, I'm going to be humiliated on some level, in some way. I mean, I'm working to get over that because we have a community griot named Brother Sage who's really on a tear to get Black people to go take care of their health because we're dying in ways that we don't need to, but we need to also have the system that supports it.
But as white people, we can't lean on people of color to change this. So I am absolutely dedicated to fostering, supporting, encouraging everything I can do to raise up more African-American nursing students to become nurses. Absolutely dedicated to that. But as a white nurse, I can't lean on Black nurses and let them take care of the race problem. I have to be just as dedicated as a white nurse in our community to be taking care of the race problem. That's not on your shoulders, that's on our shoulders. And so I want to make sure that this doesn't become a solution that happens in the Black community, that this is a solution that happens in our community, in our mixed community, that all of us are dedicated to this problem, and that it's not just my job to make more Black nurses so they can take care of it, it's so that we can take care of it.
I believe it is in White Fragility that they actually talk about that racism is actually a white problem. Yeah, it's our conversation to have. So when you talk about diversity of workforce, the question I think that they put to us in the book is to say, when you walk into anywhere, the library, a school, a hospital, whatever, who are you going to encounter? Are you likely to encounter a person who looks like you? Or are you likely to encounter somebody who doesn't look like you? And for the white person, we usually see the person who looks like us. So to your point, it's like, I don't even see anybody behind the desk, right? And so how do we encourage that diversity in workforce? And while I'm about to talk about public education, I believe that they are absolutely connected, but our public education is not doing what it needs to do to respond to the needs of all children that are in the school, right? How are we promoting health literacy in the state of Indiana? Do we teach reproductive health in the high schools, middle schools? No, we don't. No, we don't. We bring in somebody and it's a special presentation about our bodies, and then we watch a baby being born, and there you go, you've had your reproductive health education. So my point in saying that is that it's structural, and it goes right back to kindergarten and first grade, that we're already clipping the wings of kids, and all kids in this situation. But we have to do a much better job of that educational piece so that they can see what the possibilities are.
Latoya, I want to have your thoughts. I know you've been a long time community health provider. And Christin, so your thoughts on the resolution in this conversation?
Yes, well, first of all, thank you so much for even having this conversation. One of the things I always stress with whenever we're having the discussion about the resolution is that I'm so thankful that the Board of Health took the leadership in passing this resolution and beginning this conversation. As well as stated beforehand, this is not something that's new to our community or that people are experiencing. This, unfortunately, is something that's, been historically is happening in our communities, but for us to have an opportunity to have this discussion, an honest, true discussion, and to really have some action items behind it. So I definitely want to give kudos to the Department of Health or the Board of Health for being able to pass this particular resolution. I'll speak a little bit in terms of our community response, and then Christin will speak in regards to our system. One of the things that we wanted to do for our community health needs assessment this year is to be able to include those questions surrounding racial disparities as well as racism, systemic racism. This is the first time that we were able to include that into our community health needs assessment. And our community health needs assessment is something that we utilize to help us to get the voices from the community. It's not the health system developing programs that we think that the community will be responsive to, but really getting the voices to say, this is what's concerning to me. And so I know for myself that I'm very excited to be able to get the results back from that CHNA that will include that, because one of the things we have to realize, as we're always saying, that racism does affect a person's health. And especially when you think about, have they been discriminated against in the healthcare setting? Are they able to have access to providers that look just like them, as was discussed before. But then also in regards to language and cultural barriers, like you said before, that it's not necessarily just in terms of African Americans and Latinos, but what about our African population as well too, and how many of them are, discriminated against because of their cultural differences as well. So we have that included into our community health needs assessment. And like I said, I'm so excited to be able to get the results back from that because the whole point of us asking these questions is not just to ask it, but to really have some implementation strategies surrounding it. So I'm very excited to know or to be able to get the results from that so that we're able to have those implementations together. One of the great things that occurred from our last community health needs assessment is that we found that there was a great issue in regards to food deserts and food insecurity. Fortunately, when we think about these food deserts, where in those communities do they reside? We can pick out certain zip codes within our area where we do say these food deserts, meaning that, there isn't a close location for them to get grocery items, much less fresh produce. So one of the things that we were able to do is to provide funding for mobile food pantries. So, it's not a matter of when can they come to us, but how can we come to them to be able to provide these resources and services. And so we've been able to set those up in different zip codes that we were able to identify that had affecting in terms of like low income communities and definitely with minority communities as well. We also want to make sure that we're continuing our commitment of providing support with our community organizations. One of the things that I think that we're able to see that we're not able to do this alone. This is a community issue. This is a community problem. And so it's going to take all of us. I think what was said before, it's going to take all of us to focus on this and to end it, if you will. So we want to make sure that we have our commitment with providing support for those different organizations that are out there, like 100 Black Men, La Casa, MLK Foundation, South Bend Chapter, Indiana Black Expo. So a number of different organizations, as well as those partners that we haven't been able to work with previously. What are some opportunities that we can have going forward and in the future? So we're really excited about that. I loved in the resolution the piece about community health workers, because that is also something that we have with our health system. We do make sure that our community health workers reflect the community that they are working with. We have at least currently, we have female as well as Latino, African American community health workers that are able to provide some of that specified and specialized, really, I should say, services to the community. So like we said, this is a conversation and things that we've gotten into place, not because of recent events. This is something that we've been working on, but it really brings it to the light, and we're so excited to be a part of the conversation. So thank you so much. And so I'll give it to Christin.
Good evening. Thank you all so much for having me. I am responsible for diversity and inclusion for the Midwest, and I'm also responsible for community health and well-being. I'm based in the Chicago area, but I want to talk to you about our efforts in specific to St. Joseph. As an aside, I've enjoyed having our conversation today. And in giving feedback to the resolution as well, and to a lot of the conversations that we've had this evening. When we talk about racism, I think we also need to talk about the roots of our country's concerns and issues, and it's really the caste system that we've created. That caste system is a hierarchy based on what people look like. When you see someone, you place them according to where you think they fall on the hierarchy system. And that then lends itself to racism. So calling a situation what it is and the root of the problem what it is, it then allows us to say, okay, culturally, what do we need to do so that when you see someone, you see them as a relative, you see them as a friend, you see them as a sister or a brother, not based on their color of their skin or their physical attributes or the hijab that they're wearing, but because you see them as a person next to you, as a fellow human, and really tearing down those pillars of the caste system that our country has been built on 400 years ago. So when we talk about our efforts from for St. Joseph's and Trinity Health, we talk about 4 strategic efforts. One of them sits in advocacy and declaring racism as a health crisis, as a systemic crisis, and looking at the racial inequities of COVID-19 and a comprehensive healthcare system for everyone. We also are reviewing our talent processes to create equitable compensations and reviewing our talent management processes to recruit, retain, and develop talent, diverse talent. We also are reinforcing a culture of inclusion, and that's included in mandatory competencies on cultural proficiency. We're also looking at our stewardship as anchor institutions to increase our spend with diverse suppliers over the next few years by 50%. So we have strategic efforts in place that we're working on internally that will impact our community as well as internally as our colleagues and patients. But thank you for having me this evening.
Thank you. And I haven't said it, but for all of those in the audience, if you have any questions for our panelists, we're going to give you an opportunity to have your questions answered and responded to. So you can write them in the Q&A section. It's a chat or Q&A. It's a Q&A section. Does anyone have anything they want to say real quick before we start taking questions from the audience?
I just want to reiterate what Leanne had initiated, the fact that the Black and Brown community has to be able to trust the individuals in order for them to open up to or address or even conversate with them. Mm-hmm. And that begins with relationship. If they don't have the relationship, they're not going to trust the individual.
Mm-hmm. Mm-hmm. Great. Justin, do we have any questions?
Yes, Daryl, we've had a very lively Q&A. The public is thirsty for information and for action. So.
Right on.
So we're going to start. So in regards to race, is our public service population representative of the broader St. Joseph County population? And if not, what are the current barriers to recruiting professional first responders and healthcare workers of color?
Whoa, that was just a light question.
I don't know if you want to take that, Chief, or you want to take that, Heidi, or anyone else.
So I mean, I can tell you that I don't think Beacon is reflective of the population that it serves. Walking into certain meetings, I might be the only individual of color present in like large leadership forums. I think we are starting to have more conversations about being intentional in our recruiting practices and our promoting practices to make sure that we have more individuals of color and various races, not just the African American community, but currently, no, it's not reflective of the community we serve.
And also, yes, and I like to also make a reply on that as well. The fire department, obviously, unlike any other organization out there that's hiring and would like to hire more persons of color. When I got on this job, there were probably 30 to 40% more African Americans that were on the fire department when I enlisted under this occupation, but since then they've retired. And so therefore, over the last 20-some years, we haven't been able to get as many African Americans that wanted to do this public service. And we've taken upon ourselves over the last probably 10 or 15 years or so to really look at ourselves and say, hey, what can we do differently? Because it's a different concept to getting on the fire department than just walking into any other corporate or organizational job and applying, having an interview, and then getting hired. Getting on the fire department may take up to a year before you can even get on the job. And that's if you go through the written exam, go through the physical exam, go through the interviewing process, and then therefore, then you have to go through, obviously it's only done by attrition that we can replace firefighters. The city is only mandated to have so many firefighters. And so until one retires or resigns or leaves the job, those are the only positions that we can replace. We can't just hire additional firefighters. The city council, if we can convince them, I'd love to have more, but if we can convince them to pay for it, then we would have them. But as far as the African Americans and the brown, represent the brown community, the Latinos, we'd love to get more of them. And me and my staff are working diligently to try to do some restructuring, to try to create more of an opportunity for these individuals through our continuing ed with the South Bend Community School Corporation. We're trying to get into the school corporation early to try to influence and enhance some of the individuals there, that this is a great opportunity for them. We understand that we need to attract them early. We always have public education at our fire stations. We have the kids from grade school and even preschool coming into our stations, and we're teaching them all the safety things that they need to know. But now we're really going a little bit further, and we're actually putting into their mindset at an early age that this is something that they can do. When we see persons of color, of different ethnicities, of different nationalities, we are encouraging them that this is something that they can do. Now, obviously, it would be better if they could see more of them in that role that they can relate to. But at the same time, we have to take advantage of every opportunity. So all of us that are in those roles, we are going out into the schools, we're going to our churches, we're going to other community events, and we are preaching the word of serving and being a servant leader and being out there for our communities so that our communities can see more of us serving so that they would want to serve too. And along that same lines, we've got community paramedics that are going into the homes of some of our elders and some of our afflicted citizens in our communities that don't necessarily get the care that they deserve to get. And we are sending people to their homes, maybe not so much as COVID has kind of limited us to do that, to go into their homes, but we are creating a dialogue and communication with them to make sure that they get the help and the service that they need and not being limited because of where they live or the environment that they're in. We want to make sure we do this, and I'm strongly encouraging all the people behind me and with me to act and to be a part of this process to help me get more of us out there, but also help those that's out there get more of what they need. So that's what the fire department is trying to do.
Can I add on to
Absolutely.
that? I just really wanted to touch on representation and how much representation matters. One thing that can happen is if we don't see ourselves in those spaces, we will subconsciously think that we don't belong there. I've been a nurse. I graduated nursing school in 2002, and I was the very first African-American faculty member that I had ever met. Nursing faculty member that I had ever met. I was the first. And in my first year teaching, my Black and brown students would say to me how nice it is to see someone that looks like them. And I had never, when I before I became a faculty member myself, it was only because I didn't think it was someplace I belonged. So I just want to say to the people out there, you belong here.
That's good. Nice message. That's good.
Okay, thank you.
If I may add to this conversation, and I had already gone over that the Department of Health is very much committed to diversifying its workforce, and that we hope that that serves as a model for others. But there's something else too that we haven't quite talked about, and that is wages. You know, the disparity in wages that exist, not only gender, of course, but among the races. So with the Board of Health in January 1, 2019, we lifted everyone's wages, 8% across the board. Most of them received double-digit increases because we hadn't been able to give raises in forever. And we had some folks who were way out of whack with each other, way out of whack, and we had to correct for those things. And we're continuing to look at those things. It's not perfect yet, believe me, but that is something that is absolutely on our radar. And I know that that exists in many other locations, and that is something else that we need to make sure we bring to the conversation.
Well, culturally, when you think about wages, that's cultural as well. So when African Americans and Latinx folks get promoted, we know, or even when they come into an organization, we know that they are less likely to negotiate. Whereas our white counterparts always negotiate, they never accept the first offer. But it's the mentality of, thank you, we're so happy to be in this space, we're so grateful, we don't even know what to ask for. Not to mention that we Black folks just don't have those mentors in those spaces to be able to have that conversation, to prepare, to negotiate, to have that confidence, to be able to ask a question. And I appreciate everyone on the panel's comments. Jayandra, when you spoke on that, if you don't see yourself or you don't believe that you belong there, it goes with talent acquisition and talent management too. So when folks come in, historically, they're coming in at a much lower pay rate, African Americans and Latinx community members and colleagues, because they just don't believe that they're supposed to be there, and they don't know that they can negotiate for even more. So it's up to us as institutions to bring them in at the appropriate rate and range based on their experience.
And part of that, part of that conversation is not just the discomfort with negotiating. I mean, I don't seem to have that problem, but even in conversations where you're having very frank discussions about your value and your worth, it goes nowhere, and you have to wonder, how much of my emotional bandwidth do I want to spend having this conversation, trying to convince leadership that I deserve an equitable salary? You know what I mean? So part of it is, do we get frustrated? Do we not want to be seen as obstructionists or being seen as difficult, and make it centered on, oh, you're only in it for the money, when it's really, if you value me as a leader, as a healthcare provider in your institution, then you need to pay me accordingly. And so some of it is, we need to find that balance of making sure that we are very confident in what we bring to the table, and we continue to articulate that regardless of how many meetings it takes, or emails that need to get sent, or the individuals that need to be CC'd on those emails.
No, it was very much a question of equity and dignity combined.
Yeah, and if I can add to that too, just to say, and that's good that we should be able to negotiate, but also being in the healthcare field, we all took vows, doctors, nurses, we took those vows to be faithful and to treat everyone equal. But also on the flip side of that, I should not have to negotiate with you my salary if you're going to give the same person that's of different color the same thing. We got the same credentials, same experience. I should not have to negotiate with you. I should be offered that same pay.
And that's something also for the fire department, that's something that's on a positive note. All prospective firefighters, no matter who you are, whether you're male, female, African American, or any other ethnicity, the pay is the same. So there is no disparity in the pay of a firefighter. It doesn't matter what color you are. It doesn't matter what gender you are. You're all going to get paid the same amount. So that's the good positive of being on the fire department.
And I want to get a couple more questions in. Justin, are there any other questions? Or
Oh,
can you-
yes, plenty more questions than we can ever get to tonight, but we'll get to this one. How are we providing anti-racism and cultural competency education to medical practitioners? And how are we holding them accountable when they don't meet those standards?
Great question.
We're not.
Yep, and we're not either. We're not providing and we're not holding accountable. We're not doing either. Anybody know of anybody doing either?
No.
Well, St. Joseph, we facilitate and we train our leaders on unconscious bias. We started at our executive leadership team, and then we cascaded that down to our directors and above. And then we're looking to also cascade that to our physicians and our leadership teams. Accountability is a different conversation, right? We're still working on that piece.
Yeah.
So I do have to speak on behalf of IU South Bend nursing program and say that all of our graduates of our MSN and our BSN program graduate with having come through the Civil Rights Heritage Center. And so they hear from the staff of the Civil Rights Heritage Center about the history of race and racism in the South Bend community, and that they are held throughout the program to be accountable for meeting the standards of some amount of cultural competence and sensitivity, and it is threaded throughout the entire curriculum. So they are given some words and they experiment with the ideas of racism and how racism impacts health. And so I have to say that the School of Nursing is trying to produce, is doing some part to produce nurses who have some experience in this area and some expertise.
And I think it's important to distinguish between, let's have a conversation about implicit bias, and let's have a conversation about diversity and inclusion, and let's have a conversation about anti-racism.
Exactly.
Because there's a different tone to that conversation. So while we're starting to have more conversations about diversity and inclusion at Beacon, and a lot of that came from the George Floyd murder and the social rise that our community displayed, we aren't having a lot of conversations about anti-racism. We aren't holding not just the medical practitioners, but any allied health providers. We're not doing enough to hold them accountable. There might be individual one-on-one conferences, and it falls under the umbrella of it doesn't align with the mission or it's not professional, but we need to call it what it is. And until we can have those conversations and call out the racist comments or acts or implications, then we're going to be spinning our wheels in terms of solving this problem.
I also want to add on, as far as nursing education has gone, I have seen more faculty, more nursing students willing to discuss racial disparities, ready to encourage inclusion and diversity. I know at St. Mary's College, they're starting a club, the Nursing Student Alliance for Inclusion and Diversity, to promote belonging on campus as well. So it is something that we are seeing in nursing education as well, that it is being acknowledged, that it is something that needs to be discussed.
I don't think that we mentioned this tonight, but Leanne, you brought up a very valid point about holding individuals accountable for their actions. Also, if you witness someone being treated wrong, you need to speak up yourselves, and you should not be retaliated against when you do speak up. So I think that needs to be a part of it as well.
No, I think we would all agree that silence is complicity, right? If you see this happening, you're participating in it.
Yes.
Justin.
So we have received a lot of questions and comments regarding how the Board of Health connects with the community. So we'd like to ask how the community can further engage with the Board of Health regarding this declaration.
So let's see. Right off the bat, I immediately now think about, this is one of the rare few positives that have come out of this COVID pandemic, and that is we're on Zoom. So now the community can participate in our monthly Board of Health meetings We have a public comment section. Everybody can speak for 3 minutes. And we want to hear feedback from our community. So that's one way, and you can do it from the comfort of your own home, which is awesome. The other thing too is challenge us and hold us accountable to the resolution. Read the document. It's on our website, on the department's website, and you can download it. Read it and figure out what's important to you. And then hold us accountable for that. But more importantly, and this, I wanted to end at least on this, is that what I hope that this resolution does is that I want people to take this back to where they work. What are people willing to do at your organization? Where's the camera? At your organization. What are you willing to do for your organization to get rid of racism, structural and institutional racism out of your organization? And we're happy to help do it. We're happy to meet with people, help facilitate some of those conversations and so forth. But that's my ask from this meeting, is of the organizations and the people who are watching. What are you willing to do at your institution?
That's good.
Well said.
Okay.
Very well.
Justin, you want to toss another one? Do we have?
Yes. So really, I think this is the final question that kind of ties us all together. What should the community's next steps be? Especially, not just as you discussed, what are we saying, but what are we doing? What are our action items?
That's a good question.
I don't know.
I mean, I could start. I mean, we have a resolution, right? And we have to hold ourselves accountable. So I would think that our next steps is that at all our subsequent Board of Health meetings, which are public meetings, the community should hear what our progress is, right? So that I would say is a commitment from the Board of Health, that we should be able to share our progress as we are going on. And constantly, dealing with structural racism, we have to get to the core of what's going on, because we tend to focus on the smaller things, the kind of the low-hanging fruit, the band-aids, if you will, and then we feel good about that for a period of time, but it doesn't really take care of the problem. It has to be structural. So we have to go for the big questions. We have to go for the big actions and the big asks. And so I'm looking in the camera again. And I'm looking at my CEOs and the people who lead organizations, small and big, in this community. What are you willing to do at your organization to root out structural racism? That's the next ask, I think. That's where we need to go. It's the moment. This is where we are. This is it.
And I would say, to tag on to that, I would say the next step is for all of us on this Zoom call, and of course, those of us sitting here have no idea how many of you are out there, but I get the impression there's a lot of you. So if every single one of us goes back to our place of work in a healthcare agency and says, we need conversation about anti-racism, that's going to have an impact. So that every conversation, every decision that is made by healthcare agencies, every thing that is considered comes from an anti-racism point of view, that's going to change things fast. And I would encourage every person on this call to tune into a podcast, read some important literature, have a current events conversation. Lord knows there is plenty of information to read, to learn, and to form a book club in your nursing department. Every nursing department will find 4 or 5 people for whom this is a really important topic. Read a book together, get together once every 2 or 3 weeks and talk about it. Nurses can use something else to talk about right now than COVID. And so it'll be good for you. Or look at COVID through an anti-racism lens. That's a really good thing to do too. So that's what I would encourage. I think those are next steps.
And I can add, if I can just add to that, and I'm hoping that maybe this here Facebook Live will be posted on your page for a while. Everybody can share it with a friend to get the word out.
Good idea.
And I actually have one more question myself, and it's really about the implementation of the resolution, and particularly around intervention. So a number of people in the community are concerned about police reform and ensuring that, our local law enforcement in particular are serving the community the best of their ability. And one of the ways that it's been talked about is that our law enforcement often responds to incidents that don't really require people with guns showing up. And those kind of situations escalate. And there's often implicit bias, structural racism that's at play. I mean, George Floyd being the grossest example. I'm really excited about this notion of interventionists and having trained people enter into the community, addressing mental health crises or other interpersonal crises that don't warrant the level of law enforcement or arrest, or there's other ways of resolving these issues.
That's right.
And so how is that working out? And do you have a strategy for like broadening that program? What's the relationship, and are you engaging with law enforcement around that and other first responders?
That's right. So actually, there's been some real recent developments on that. So our health officer has already met with Sheriff Redmond and Chief Raskowski about this. And they are both enthusiastic and welcoming of changing things and doing things differently. And there's a couple different models. So there's a model where the call comes in and dispatch can actually choose, is there violence happening, right? Or is this a nonviolent situation? Because a nonviolent situation, I might be able to send mental health providers instead, right? So there's that kind of a model. And then another model is where a mental health provider is always riding with a police officer. So instead of having two police officers in the car, there's a police officer and there's a mental health provider. So this is what's on the table, and it's really exciting. And the cool thing is that you've got health intersecting now with law enforcement. That we never thought that that's the way we have to go. And now we're suddenly seeing that we're all partners for the same reasons, right? So this is again, it's a unique time, and we really do have really strong leadership in this community, and we're going to hold our health officer accountable. We're going to continue to ask them, so how have those conversations go? What is the next step? So there'll be more to come. So stay tuned.
Great.
Can I add to that also, Daryl? I think it was last night where the young fellow, Walter Wallace Jr., was actually shot as well in a particular situation. He had a history of mental health. I'm not sure if they knew it at the time, but nevertheless, had they had a mental health officer there to de-escalate the situation, that situation probably would have turned out differently.
Right.
And that's precisely, and I really like that notion of health and law enforcement, first responders, kind of having the community-wide responses that are actually addressing the needs of the community and not the same old structural, because the normal is racist, is racist. And then we have to do something different. And so I applaud the Board of Health, and both in your creativity in addressing this and the commitment to it. And I want to thank all of our panelists as well for participating, and for our administrators. And Dr. Fisher, thank you for coming back on. And I guess that will conclude our program for tonight. Did you want to say anything else, Barbara? Is there anything you wanted to add?
I don't think so. I think that we're good. Thank you for the very healthy, robust conversation. I mean, there was no tiptoeing through the tulips here tonight. We got to the meat of the matter. So I hope that we continue to have conversations, and we hope as an inclusivity council to have further conversations. So stay tuned, we'll be doing more.
And I want to just kind of end with, to take the words of everyone, in particular Heidi's challenge to everyone. Take this back, Barbara's challenge, have these conversations and discussions with your colleagues, with your friends, with your families, that this is something we have to address as a community. And so thank you and good night.
Good night.
Good night.